Okay, so it's time now.
Okay.
Are you ready?
Yeah.
Always ready.
Okay. So welcome everybody and good afternoon. Thank you for attending this webinar on palliative care and neuromuscular disorders organized by Euro-NMD in partnership with European Academy of Neurology and ERN-R&D for rare neurological disorder. Thank you to our today's speakers, Professor Tracy Willis and Derek Willis, for honoring us with their presence with this interesting topic. So a little presentation of our speakers. Tracy Willis is a dedicated pediatric neurologist with a special interest in neuromuscular diseases, both pediatric and adults. She is now currently the clinical lead in neuromuscular disorders at Robert Jones and Agnes Hunt Orthopedic Hospital and Birmingham Children's Hospital and visiting professor for Chester and Shrewsbury University, contributing to the master's courses, particularly in medical genetics. Derek Willis is currently a medical director for Severn Hospice, which serves Shropshire and Mid Wales in the UK. His role includes working with the local neuromuscular services to look at palliative care for adults with neuromuscular disorders. He has helped write national government policy on this. He is also associate editor for the British Medical Journal of Supportive and Palliative Care. He is studying also a philosophy degree. Today's webinar will cover the wide range of palliative care in neuromuscular disorders. Thank you again, Professor Tracy and Derek Willis, for attending us. The floor is now yours.
Thank you, Elizabeth, and thank you for that very kind introduction. So as Elizabeth said, we are going to be doing a double act today. Both myself and Derek Willis will be talking to you today about our experience of palliative care and neuromuscular patients and how we have done this with our service. So the aims today will be to go through and discuss the palliative care journey with our patients in the neuromuscular clinic. Who do we see? Why do we see them? And how do we sort of set that up? Look a little bit about transitions and when these transitions happen into palliative care. The emotional psychology and the quality of life of these patients. And then the role of the hospice, either that would be the pediatric hospice, but also the adult hospice. We'll touch a little bit on emergency planning and also advanced care planning and symptom control. But we'd be really grateful for people to put their questions either in the chat or the Q&A facility. And at the end, we'll be more than happy to try and answer some of these, although we might not have the answers as this is still quite an evolving and emerging specialty. So I think when we look at palliative care and look at our patients, the first strategy for end of care life was developed in 2008, and certainly in the UK, the Department of Health had a commitment to provide this personalised and coordinated end of life care. And I think that's where we start thinking about advanced care planning and looking at a process which is an opportunity for us to discuss with our patients, their families, of their needs and preferences of what they would like to happen when the time came for them when they were dying. And this is a tool that can be used and shared with other health professionals that are involved in that patient's care. However, in the neuromuscular services and neuromuscular care, there's really been a lack of that coordinated palliative care and services, particularly in the adults, and very little use of advanced care plans or emergency care plans. And in 2017, David Abbott from Bristol in the UK published experiences of young men with Duchenne muscular dystrophy. And this really showed that there was a lack of discussions about end of life care. In fact, it became evident that these young men wanted those conversations, and they really felt that it should be the professionals that were starting those conversations off, and it wasn't something that they wanted to bring up. And this has been echoed in a few more publications that have been seen, particularly from the Australian group, again, reiterating the fact that these young adults, and particularly the Duchenne group, wanted these conversations initiated, but initiated by their health professionals, and particularly by their health professionals that knew them well and that had been with them through most of their diagnosis and treatment. If we look at pediatrics, so Together for Short Lives has produced this definition of palliative care, particularly for children and young people with life-limiting and life-threatening conditions. And they very much stress that this is an active approach to care. So a lot of families and a lot of patients feel that when you say palliative care, that that's almost giving up and that there's not going to be anything there for them. And it's actually discussing with them that this is an active part of their treatment still. It's a different aspect of their treatment, but it certainly is very active in what you do. It's very holistic, and that you keep a lot of the medications that they're already on, they keep those to prevent any symptoms, but that it's a different phase in their condition. And it tends to embrace all the elements, both the physical and emotional, but also social and spiritual elements of their life, and to improve their quality of life and give support to the family and that child or young person. And so when we look at Duchenne muscular dystrophy, because this is a condition where there's probably been the most work done on with regards to standards of care and how to look after young people with Duchenne muscular dystrophy, we very often use this as almost a tool for our other neuromuscular conditions that may not have all the aspects that Duchenne has, but it very often will have some of the elements. So, for example, some limb girdles may only have the respiratory aspect along with the skeletal muscle side of things. But
sorry to interrupt, Tracy. It's Antonio. We are seeing a square in the middle of the screen that doesn't look very pretty and does not allow to see your slides properly. I would suggest that you stop the sharing and restart the sharing, and then we'll you have, yes, and now start the sharing again, and then we'll edit the video.
Yeah, so I'll try it again.
That's perfect. Okay, thank you.
Yeah, so can you see my next slide? Oh.
We see the one saying definition of palliative care. Yes, now we see the one that you were on. Yes.
Yes.
Thank you.
Okay. So yes, with the international standards of care, these were initially published in 2010 for Duchenne muscular dystrophy, and they were republished again as a tripart in 2018. And this has really sort of echoed all the aspects of looking after people with neuromuscular conditions, that MDT approach, interdisciplinary management with so many professionals being involved with the care of these patients. But what was the important thing that came out with the latest standards of care in 2018 was really to look at emergency management, transitions of care across the lifespan, and psychosocial care. And I think this is vitally important, particularly as these patients are living into their third and fourth decades. So learned a lot of Duchenne and had a multidisciplinary level. But the patients that we see in our neuromuscular clinic are not all Duchenne muscular dystrophy. And so some of our patients who need that palliative care input have myotonic dystrophy, some have FSHD, and some have SMA. Some of our limb girdles and Becker muscular dystrophy will need some of that input from the palliative care teams. But also, as our neuromuscular patients are getting older and surviving longer because of improved treatments and standards of care, a lot of them are having comorbidities, and this may involve palliative care, again, if they have the emergence of a cancer. That means that they need palliative care from that point of view, not just from their neuromuscular condition. So I think it's been important to look at the standards of care that we've had, particularly with our patients that are surviving longer. In the past, Duchenne muscular dystrophy very often was late teens where they died, whereas now the mortality and their age of death generally is in the mid-20s to late 20s. And as I said, some are surviving into their third and fourth decade. And so we have these new challenges to really focus on quality of life, well-being, self-management and looking after themselves. And I think these palliative care discussions can be helpful at different stages. And this can be around diagnosis, particularly if it's an adult onset condition. But with our Duchenne muscular dystrophy patients, it's very important to have that discussion again about their diagnosis as they're transitioning from pediatrics to adults, because the diagnosis was made when they were a child and all that information went to their families, not to them. And so it's important to have that discussion with them and make sure they understand what their condition means. Obviously, when they have, sort of points when they, sort of are sort of key events in their condition, then again, that is a time to have that discussion. When they lose ambulation, when they start on ventilation, these are all events that mean that we can have that discussion with these young people and adults about what they want from their management. So transitioning from childhood to adulthood is a big one, and particularly with our Duchenne muscular dystrophy patients. Some of them have experienced hospice care as pediatrics, which is very different, as Derek will say, to adult hospice care, particularly in the UK. And very often, sort of they haven't had those discussions about, what their diagnosis means. A lot of them will, are internet savvy and will Google a lot of it. But a lot of the time they want to bury their head, and it is up to us to broach this subject and start going through these things with them when we're doing transition, so that they understand their condition, they understand what it means, they understand the importance of maintaining their appointments and sort of keeping themselves as healthy as possible. It's improving their resilience as well, because neuromuscular conditions that are progressive is sort of quite a big thing for them to take on, particularly at teenage years when there's so many other changes happening in their lives. So like Duchenne, neuromuscular disorders really are a continuum, a succession of disease milestones. And you can see here the sort of cartoon essentially of what happens from diagnosis through to eventually death and loss of different skills as they go through this. But we see this with our other conditions in neuromuscular, such as Pompe disease. They go through very similar conditions. With myotonic dystrophy, with limb girdle muscular dystrophy, again, very similar milestones. So with this comes a lot of emotional and psychosocial needs. So we really need to acknowledge these challenges, and particularly with some of the neuromuscular conditions, there can be cognitive and developmental issues. And again, it's trying to sort of address those in a sensitive manner. and support the parents. So a lot of these parents are getting older when their son, particularly with Duchenne, gets into their 30s and 40s. These parents can be in their 60s and 70s. And this can be very difficult for them to cope with, as well as the thought of their child, even though they're adult, dying before them. So there is a lot of issues that need to be brought on board and particularly recognised, and give the family time to discuss those. So having sort of coordination, having care workers that can navigate, the families through all this and help with all these various needs is vitally important. And certainly our charities that we've got that help our families through this, and we know that other countries have similar setups with the muscular dystrophy groups. Certainly in the UK, we've got the MD UK, Muscular Dystrophy UK, and Action Duchenne, particularly for our Duchenne families. But there are certainly, sort of a lot of other groups that are set up to support those going through neuromuscular progressive conditions. One of the big aims, particularly with our young people, is that quality of life, making sure that they achieve a rich and fulfilling life. And certainly one of my young lads said to me the other day, he's found COVID actually quite revolutionizing for him, because actually he can work from home as well as anybody else in front of a screen. And nobody knows he's in a wheelchair and that he needs a ventilator at night. So he can apply for a job now and work from home using his laptop as good as anybody else. And so he feels that actually for him, the pandemic has been something that has given him that extra bit of life and fulfillment. But it's important, particularly for our young people, that we try and recognize this and aim high for them, that actually they can aim to get jobs, employment, personal relationships. That is also another biggie for some of our lads with Duchenne muscular dystrophy. That is one of the things that they want to achieve, is a job that is paid, but also a personal relationship. And I think that's important for us to address, particularly in the clinics, and look at with our families. It's very difficult to assess quality of life, and I think as clinicians, we assess it very poorly. We very often feel that our patients probably have a poor quality of life, but when they do the assessments, it comes out surprisingly much higher. But we do have to recognise that a lot of our young people do have a level of depression and anxiety, and actually treating that can help significantly. And it has a knock-on effect of a lot of things. So treating their anxiety and their depression, whether that's with pharmacological treatment or with psychology, very often will help other aspects of their quality of life, such as their pain and their perception of pain. So it really is important to address. So why do quite a lot of our neuromuscular patients end up in hospital or sometimes die in hospital? And I think it is really difficult sometimes to recognize end of life in some of our neuromuscular patients. They very often will have this progressive deterioration with either cardiac, respiratory, skeletal, or all as time passes, but will for quite a long period of time appear to be quite stable with no changes. But something very small, a small chest infection or a cold even, can end up with them resulting in ITU. And it is very difficult to know, is that the time when they are going to die, or will they recover from that? And very often, when they do have an acute episode, that is certainly a time when we need to look at their advanced care plan, look at their emergency care plan, and decide and talk to them and discuss with them whether they want to make any changes to that. Do they, when they have their next acute episode, not want to have all the resuscitation that they've had in the past, or do they still want to go down that route? And I think that, you know, sort of is very important. Emergency care plan, you know, we want to focus on them staying well, staying safe. You know, we always think about, you know, these emergency planning preparation for if they're having anesthetics, being proactive with their respiratory and cardiac management. You know, talking to them if they are admitted with a chest infection. Do they want to progress to having a tracheostomy, or do they want to try and manage with non-invasive ventilation? To have alert cards and apps which give the other medical teams that may not be au fait with neuromuscular the information that they need. Emergency plans that have all the contact details of their neuromuscular team so that they can be contacted for further advice. For pediatrics, we have open access usually to their local children's assessment unit, and that's really important. And again, like advanced care plans, we update these regularly, and these are signed off by both the families and children, but also with the adults themselves as to what they want to happen. So challenges of initiating an advanced care plan. As I said right at the start, you know, we know with various studies that have been done over the last few years, particularly with Duchenne muscular dystrophy, that these young men want to have this discussion, but they don't want to bring it up. They want it to come from their clinicians who they know. And that means that the clinicians have to have that confidence of initiating that conversation. And timing of that conversation can be very difficult. You know, I've had one of my young lads who, you know, sort of, I tried having that conversation with him quite a few times. And it wasn't until he was ready that he came into clinic one day and said, right, I'm ready to discuss that now. And I think, you know, we have to be there for them and, you know, try and initiate, but obviously be aware that that time may not be right for them and that they will come back to you when they're ready. With parents, you know, they worry, they want to protect their child, even if their child is an adult. And they very often find this upsetting, and we very often have to do some preparatory work with the parents and family first before we start bringing it up with the young person themselves. Sometimes there can be conflict of wishes. So parents may want something different compared to the young person involved. And actually, if that young person has capacity and what they are saying they want to happen is, you know, sort of quite feasible, then, you know, we really should be going with that young person, that young adult, as to what their wishes are for end of life. So I think this is very important. The benefits of advanced care planning, I think, are immense. And you know, we always try to say that this is a positive sort of thing that we're doing. It's not something that we look on as being dismal or gloomy, and that actually this is empowering the young person and the family. It's an opportunity for them to discuss their fears and wishes. And we very often find that initiating this, you know, very often comes from when they've had a physical change or they've had an acute episode, that actually we use that to then say, I think it's probably time that we had that discussion and talk about this, and what do you feel about the next time this happens? But actually, you know, it can give them that sense of positivity and empowering. One of my patients with FSHD, who is getting quite elderly now and you know, has got quite a lot of difficulties and has been ventilated for a long time. I remember that she said we'd gone through an awful lot of things and a lot of different aspects to her healthcare, and obviously gone through the ventilation side of things and the increasing ventilation that she was having during the day. And we then made an appointment to talk to her about advanced care planning and go through emergency care planning with her and what her wishes were. We discussed this with her, and then we sort of said that the specialist nurse would come out to the house and go through it with her, but we would give her the paperwork so she could have a look at it herself and go through it in her own time. And her response to us was, "Oh, I'm so pleased you've said this. This is what I've been waiting for, and this will be the full stop at the end of everything that I've done. I feel that I've got everything covered, and this makes me feel a lot better to have completed this." Now, she wasn't about to die, but she felt that this was really sort of pulling everything together holistically, and that she felt this had taken a big weight off her mind, that she could have these discussions. So I think it is quite revealing sometimes when we discuss this with our patients. I think as medical people, we are striving always to prolong life and give people sort of as much good health as we can. But actually, this is just as important to have these decisions alongside the active health management and this parallel planning. So certainly, sort of I would recommend looking at these advanced care plans with the families. As I said, the palliative care journey for neuromuscular patients is very different to cancer patients. And we know at the beginning that the diagnosis very often is life-limiting if we look at our Duchenne's. But they will have episodes where they seem extremely stable for years and years and years. But then we'll have some episodes of critical illness, and those episodes will possibly knock a little bit off their baseline each time until really they tip into that end of care, palliative care area. And so as a project a few years ago now, we started looking at a traffic light system to identify our patients in the neuromuscular clinic. And this was taken off the back of the spectrum of children's palliative care. And with all our patients that were tipping into the red aspect, we definitely were prioritizing these to discuss advanced care plan, and similarly with the children and young people collaborative ACP. And so this is what our traffic light system looks like a little bit. So our blue patients are people with neuromuscular conditions, but they're not expecting to be life-limiting. Then our green patients are those that haven't got any respiratory support yet, normal cardiac function, ambulant or a wheelchair user, so very good from a neuromuscular point of view. But then with our amber patients, those are ones that have started NIV. They've got cardiomyopathy, they're wheelchair users, they possibly have gastrostomy feeds, acute admissions to hospital are increasing frequency. So we wouldn't be surprised if our patient died in the next few years. So discussing and starting that planning is important. And then if you look at our red patients, then these are ones that we want to make sure that have updated ACPs every year, and we're keeping those up to date and rediscussing what the patients and their families want with this. So with that, with the children, we have in the UK the Child and Young Persons Collaborative Advanced Care Plan. And this has a summary of the patient's diagnosis and medical needs. This is shared with all the professionals and is reviewed every year, or if there's an acute episode that happens and we want to revisit their end of life wishes. And it's signed by the parents and ourselves when this is done, and we distribute this round to the main carers. And similarly for the adults, we have the RESPECT document, which again is a summary plan for emergency care and treatment. But also we're developing the integrated advanced care plan, which is very much like the child's collaborative ACP, which incorporates all these discussions and anticipatory planning for these patients. So I'm going to hand over to Derek Willis to talk a little bit about the palliative care specialist and what they offer to our neuromuscular patients.
Hello, everybody. Really, really nice to meet you. I have to admit, I'm feeling slightly overwhelmed with being a simple palliative care physician and surrounded by very eminent neurological people who understand all the things that I couldn't understand at medical school. So thank you very much for inviting me along. And my perspective is very much from a palliative care perspective. Just because I know that there are various countries represented here. The type of palliative care that I'm talking about is UK, where adult hospices are mostly funded by charities. So there's about a third of government funding for the organisation that I work for, and 2/3 of that is provided by people fundraising for us. Palliative care, which was, it's argued about where it started, but being an Englishman, I'm going to claim it for England. Started at St Christopher's in London, really was to look at improving end-of-life care and to be a place where people died and were kind of given symptom control well during end of life, with the idea that this would be kind of taken up by the kind of general healthcare. So that really kind of didn't happen. And the extent of what hospices have taken on within England and the UK has expanded, and it's no longer end-of-life care so much, it's symptom control, and it's not so much just cancer, it's kind of spreading over to other life-limiting conditions. And generally the standard that each hospice is looking to promote is for a third of its kind of referrals to become from a kind of non-malignant cohort. So neuromuscular diseases really were an entirely new thing that I'm not really sure that very many hospices in the UK had come across, and it's sort of something we've stumbled across, starting to look at, and are starting to get some knowledge of what this is. So if I was going to summarize the types of patients that I'm starting to see with the services that we're offering to neuromuscular patients here, is that there are new diseases, particularly for us as palliative care physicians, that we've never seen. So generally patients with myotonic dystrophy, they're a new cohort of patients for us, which when you look at it seems a bit crazy that we've not seen these people, because they're multisystemic, the life-limiting, as you know better than I do, their prognosis generally doesn't go beyond 50 years. And a lot of it, the holistic care that they need is involved in kind of supporting the family, because as you know, generally it's something that each tier of the family will have expressed the disease. So for us, myotonic dystrophy fits the bill of what palliative care delivers, but is a whole group of new diseases that we've never come across. Also, there's these new diseases that we've never seen, but who are living long enough that they actually have what we are used to treating. So I've seen several people who have, it's FSHD in particular, who developed cancer at the same time. And the worry was the cancer side of things. And actually the symptoms that we're presenting would be something that I would be really happy looking after and really comfortable with. But some of what I've had to do is to reassure hospices in other parts of the country that the people that we've seen in our clinic who have a FSHD, the pain that this person's got is nothing to do with their neuromuscular disorder, but everything to do with the cancer that they've got. So going ahead and kind of do what you do for the cancer, but just being aware that this patient has other comorbidities that might limit what you can actually use as far as medication goes. And then the third group are those patients who aren't a new disease in the fact that they've always been adults. It's that they're a kind of new disease to everybody, if you like, because you could argue that Duchenne muscular dystrophy, with its change in prognosis, is starting to show features and signs that people never expected to see. My understanding is that neurological symptoms are a feature that you would see in someone who got Duchenne muscular dystrophy as they got older. And so some of those things that we're seeing are coming through as a new disease. And for us, we would generally only see patients who are above 18. So patients with Duchenne muscular dystrophy would not be under the realms of an adult hospice. Now, a lot of the patients who've got Duchenne muscular dystrophy are living past where a child hospice will be able to provide care for them. So they're now starting to come to us, and we're having to work out what palliative care looks like for this group of people who didn't ever live long enough for us to actually be part of their care. Next slide, please. So as soon as I say the word hospice and I do palliative care, it's a really good conversation killer at dinner parties. People generally don't want to talk about my job. And a lot of physicians and kind of healthcare professionals have quite a view about what we do. So what is it that I think that you might be thinking about and that you kind of might have an attitude towards palliative care? Well, I've had several doctors saying that they don't want to refer patients to me, and in particular patients with neuromuscular disorders, because hospices are too gloomy. And that what we do is we just talk about death all day. Whereas actually what I would argue is that what we're trying to do is to give people quality of life back, and also give people a sense of control. So one of the triggers for us trying to start doing something about this is that a young lung died at home around the corner from where I work, and we weren't involved. And actually kind of hearing about what was going on, the hospice that was on his doorstep could have helped make his death better. The other thing that a lot of people think is that as the hospice, we provide respite, because again, I'm unsure about in other countries, but in the UK, most or some of what children's hospices would provide is respite for families. And adult hospices started off their existence offering respite to people, but now there are other places that do that, and generally that's not viewed as being what an adult hospice would do. So some patients come to us expecting that we will give them 2 weeks break from their family 2 weeks break, and that'll happen over a rolling rota, and we don't do that. Some people are also worried that what people in palliative care try and do is to take over the entire part of looking after the patient for you. It may seem strange to you why Tracy's actually talked about advanced care planning. And I was very clear from the beginning that it kind of wasn't my job to do the advanced care planning bit. Because as the paper that she quoted, Abbott says, is that actually it's their existing team that those patients want to have that conversation with him. To wheel in me to be the person that has all those conversations compounds the factor that what I'm about is death and gloom. Actually, you need to have that conversation with someone you trust, you've built up a rapport with. So what we're not trying to do as the hospice is to take your patients off you. We still need you to provide all the excellent stuff that you do on neuromuscular diseases, because we don't know about that. But what we can do is provide advice for the symptom control part. And together, which you're used to working as multi-professional and as are we, actually we just need to kind of widen our idea about what multi-professionals are. I've already mentioned the fact that I really don't want to do your ACPs, and actually that bears repeating, because I can do ACPs for everyone, and actually that's quite a time-intensive conversation, and one that I don't think is a one-moment one. I think it's something that you actually have small parts of it as you go along. What do we actually mean by symptom control? And kind of what are episodes of care, and when do we refer to you? Well, hopefully giving you some idea from the traffic light system gives you some idea of when palliative care can be involved. So kind of what I want to say is, we're not about death and dying, we're not about respite, we are actually about non-cancer, and we are about symptom control, and we're about being part of your team rather than taking over from you. Next slide. So this is the system that we developed, the traffic light system. So when during the team's MDT, someone is flagged up as red, that is when they are kind of thinking that involving me would be sensible. So involving me from the point of view of discussing symptoms, or involving me of trying to work out where the local palliative care services are, so that that person can actually get in touch, and the local palliative care services can know that they're who they are. Again, I'm pretty sure that this is true worldwide, that neuromuscular disorders are so specialized that actually there are few centers within each country that deal with this disease. So the hospice that is near to the center that you're working from is probably different to the palliative care services where the patient actually lives. And so what we've tried to do is to use me as a link to those particular services, to refer those patients into there and act as a bridge, if you like, or a reassurance to the hospice that actually we kind of know some stuff about this, and I'm here to be an advisor, but also these patients do need us, and that we're trying to work out what exactly that need looks like. Just before I go on, we're really happy to ask questions. And what generally happens if you can't type like me is that in the last 5 or 10 minutes, you're trying to type the question in and then the question goes back. Please keep typing stuff as we go along. And what we're going to do is to kind of pick those questions at the end. So we will keep talking, but we'll leave about 10-15 minutes for questions to go. But please try and type those now, because it just makes it easier for the organisers to work out what it is that you want to ask us or challenge or tell us we're wrong or saying what we're doing is brilliant on. So just if you've got anything, keep typing away. That'll be really helpful. Next slide, please. Okay, so these patients that I'm talking about aren't particularly a patient. What they are is they represent groups and types of patients that in the 2 or 3 years that we've been running the clinics and my involvement with neuromuscular are the types of patients that I've come across. And to just give you a flavour of here's what we've done. So patient 1 has myotonic dystrophy, and I wanted to start with someone who's got myotonic dystrophy, just again to hammer home that when we started, we thought that most of what I was going to be involved with was Duchenne muscular dystrophy. I sort of stumbled across the patients with myotonia. I know that this isn't true worldwide, but there is a tradition within England or a practice that we look after patients with motor neuron disease. Now, they are very distinct diseases, but there's a lot with regard to the care of the multi-system care that is kind of analogous between the, or similar between the two types of disease. So some of the patients I've had muscular dystrophy, there's been discussions about their NIV. A lot of patients with myotonic dystrophy that I've found, because of their difficulty with speaking up, really don't like going to hospital because they often feel that they're ignored, or as you know, there's a kind of motivation problem or a slowing down, or indeed full-blown depression with myotonic dystrophy. We've tended to find that we've been advocates for these people who sometimes don't feel they've got a voice, or sometimes being an advocate to help the relative who a lot of the time is kind of elderly, who's caring for this person. We've had patients who we've started using oral antibiotics, or indeed, we've actually given IV antibiotics on the inpatient unit that I work on attached to the hospice. So instead of them actually going into the hospital to have those, as part of a symptom control thing, we've actually given IV antibiotics to some patients who've got myotonic dystrophy. In the past 2 or 3 years, I've had about 4 or 5 patients with myotonic dystrophy referred to my actual hospice. So this is what this picture is. This is Telford. This is part of where I work. So it's not necessarily just from the clinic at the Neuromuscular Centre. I've got 4 or 5 patients who are on my caseload from the actual geographical hospice that I work in. And 3 out of those 5 people have died. So again, it's kind of that, and whereas the patients that I've got with Duchenne muscular dystrophy, I'm still involved in and kind of dipping in and out of their care. So I guess if I want you to take anything home from patient 1 is to go think about myotonic dystrophy. There is a lot that palliative care can help with. It's just, I think that sometimes they've been forgotten by hospices. And as we spread out and start looking at more neurological conditions, myotonic dystrophy absolutely has needs that hospices can meet. Patient 2, please. I wanted to talk about something which wasn't deaf and dying. I've had about 5 or 6 patients coming to see my actual hospice, and then probably about equivalent number at the actual Neuromuscular Centre, where actually what we've been looking at are symptoms that young men with Duchenne muscular dystrophy have had. The biggest thing that I found, which is really surprising, which I'm not sure whether you're surprised, is the amount of pain that these patients have. It's generally neuromuscular or neuropathic pain. And given that it's chronic pain, we try and stay away from opiates of oxycodone. There was a bit of a move to use those about 10 or 15 years ago, but now knowing what the long-term sequelae are of opiates, we're not encouraged really to do that. So Butrans patches and mirtazapine. So mirtazapine is an antidepressant, works very well for neuropathic pain, and actually has no cardiac symptoms or side effects. So those tend to be the 2 things that I've used. Also, a lot of patients are very worried about getting constipated. So opiates don't tend to go down very well because of the constipation that they cause. And as I'm sure you know, NG feeding, and because of the gut problems that patients with Duchenne have, it's often constipation's a real problem. One of the things that hospice has actually also done is that we've provided a young adult group where basically we provided the space within the building and said to these young men. What do you want to do? What do you want to do with your group? We will host it. We will provide you a space, but we're not putting it on for you. That's over to you. And the reason that I've put a fire in is that they actually built a campfire in the grounds of the hospice, which I'm still trying to keep quiet. But just to make an adult hospice a centre where patients with Duchenne muscular dystrophy can run a group themselves, be with other people that actually have the same condition, and then look at some of the things that they actually want to look at. It's been incredibly positive. Obviously, I don't know if you've noticed, there's been a thing called COVID that's happened over the past year and a half. That sort of meant that this kind of things reached a pause, but it really was starting to reach a critical mass of people going through. So what do I want you to take from this? Patients with Duchenne muscular dystrophy, the stuff that I've mainly been involved in is with symptom control. A lot of them have pain. I know that there's a paper whose reference I can't remember, but I think it's limb-girdle muscular dystrophy, where they estimated how much pain that those particular patients would have. And I think it was in the realms of about 50% had pain. So there does seem to be a kind of a tendency to actually kind of have pain from the condition itself. Obviously, not just drugs, but some of this is looking at the wheelchair and the cushions and the position that's there. But the drugs that I'm using, I've used in palliative care, but tend to be used in a different order to what I'd be using for my patients who actually have cancer. Next slide, please. And there are 2 patients that I've been involved with who've got had end-stage Duchenne muscular dystrophy, who wanted to die at home. All kinds of discussions about withdrawal of NIV and whether withdrawing the NIV was kind of going to be part of the end event. And it tended to be stopping their cardiac implanted devices, or that the patient made a decision that they didn't want to have an implantable cardiac device. And part of this has also been trying to let the local hospice know about these patients, provide the care for patients at home, and also making sure that the medication that they may need, that's the phrase for just in case drugs. So for people who have anxiety, making sure they've got some subcut midazolam. If they have pain or breathlessness, if they've got some subcut morphine, making sure that that's all set up at home. I was surprised when I first started doing this, because I thought most of my work was going to be revolving around this. And actually, my work with neuromuscular patients, this is actually the least amount that I do, particularly for that group with Duchenne muscular dystrophy. So what I want you to take home from patient 3 is to say, look, there is stuff about end-of-life care that we can help with. And some of it is about actually keeping the patient at home, because as Tracy's already intimated, a lot of these patients are going into hospital, which generally is not the place, if you ask them, where they'd want to be when they wanted to die. And actually, we can help facilitate patients staying in their preferred place of death rather than ending up being in hospital. That is, of course, if the patient wants to be at home. So I'm getting the hint that I need to go on by the fact that my slide's been changed without me asking. Just really quickly, how do we deliver all this? Next slide. So we developed symptom control clinics. The symptom control clinics were in the neuromuscular centre. They weren't in a different place for the patients to go to. We then discovered that there was this cohort of patients who lived on my doorstep. So we started to do 2 different types of clinic, or 2 different geographical ones. One which was my hospice, and one which was the central neuromuscular centre. And then gradually the patients became part of my regular caseload for those patients that were within my catchment area. It's symptom control clinic. We run 4 times a year. There is an argument that that's not enough. And actually what we've started doing is seeing more of the patients with myotonic dystrophy. And the emphasis has gone towards myotonic dystrophy. And then the guys with Duchenne or the limb-girdle are coming in as and when they need it. Next slide. And I've already touched on this, but some of this is about getting the patients used to the fact that they are now under an adult hospice, that the adult hospice is different, and that some of what we're doing is trying to show them where the building is, and for them to normalize being in the building by giving them control of what they actually do in their young adult group. Next slide, and I think that might be back to the other Professor Willis.
Yes, thank you, Derek. Yeah, so I was going to say, in the interest of time, we'll just whiz through this. So I think, as Derek's said, you know, sort of the importance for this takes a lot of obviously staffing and, you know, sort of being able to run all these various clinics and supporting these young people as well, particularly with the young adult groups, but involving the community, the hospice, as well as the acute staff is challenging to sort of keep everybody informed. Obviously, you know, sort of this is an area that is quite emotive, both for clinicians, but also for the families and the young people. So certainly sort of doing this in a controlled manner and in a safe manner and in a place where young people feel supported is important. But it's also important for the professionals and the clinicians to be able to debrief and discuss case management, because this can be, you know, very difficult, particularly when you've known somebody for a long time. So I think certainly for our neuromuscular patients, palliative care and advanced care planning is an essential and really important part of the care of our neuromuscular patients. I think we need to be very open as to when we start to initiate these conversations for patients and the parents and carers, and that looking at this as being proactive and a very empowering part of their journey is paramount. We've found that using the traffic light system has helped in our regular weekly MDTs to identify patients that we think should be coming to symptom control clinic, and that we would you know, sort of discuss this with them, but also making sure that their advanced and emergency care plans are up to date should anything happen. So, and as Derek said, we tend to run a hub and spoke sort of model where, you know, we have Derek with that experience that he's gathered over the last few years, but he will feed out to other hospices that are more distant to us, but that have got patients with neuromuscular conditions, and he can share his experience. And having that MDT approach and establishing those relationships, particularly with the patients and the families, is essential for them to have their needs answered and for those conversations to be had. So I'm going to finish there. We'll leave up some of the references that we've obviously used in this talk, but hopefully that gives us a good period of time for people to have questions, and that we can have some discussion about sort of palliative care within the neuromuscular setting. So thank you.
We thank you. That was a wonderful presentation. And I hope that everybody is as enthusiastic about it as I feel. We have one hand up of Edjalma. Do you want to unmute yourself and put some question, Edjalma? Well, I have lots of questions. I was obviously reminded of a system that I knew in the past and some of the characteristics that it has. I was thinking that across Europe, unfortunately, not all the countries have advanced care plans or emergency care plans. And I was wondering if you could give some piece of advice about the main stakeholders that you should involve if you want to forge your care plan from scratch. Is it too much for asking?
I don't want to hog. Have you got any thoughts on that, Tracy, as far as neuromuscular goes?
I mean, I suppose from our point of view, so we did for the adults, because there wasn't anything out there when we initially started doing our emergency care plan, was, you know, sort of involving all the clinicians that are involved with the patient. So particularly it was with our Duchenne population that we started it with, and it was particularly with our cardiology team and the respiratory team. So a lot of it was around looking at if they had an emergency admission, what would they like to happen? So we went through various questions, and we asked some of the patients as well, as to, what do they want to have on this emergency care plan. So it's about, sort of how far they want to go. And it was sort of supportive care, sort of, and this is in a document that we drew up. So it's supportive care, IV fluids, sort of right through to sort of looking at, do they want a central line put in? Do they want catheters put in? Do they want invasive ventilation? Do they want a tracheostomy? And these are all sort of yes, no answers that the patients can sort of say yes or no to. And we redo it every year and they sign it. But over time, we've sort of developed it, sort of as we've had feedback from families and the patients themselves. And, we distribute that to their general practitioner, their family doctor, but also to the ambulance service. So we've had quite a few meetings with our ambulance service in the region that we work in, that, sort of they can have an alert on their system that if they get a phone call that's from one of these patients with an emergency care plan, that they know that they've got documentation on them. And this means that they can be taken to the appropriate hospital. So, very often it might not be their local hospital that hasn't got all the facilities, but they would take them to the main hospital that would be able to offer the respiratory support, for example. And the patient's consent to that care plan being distributed to those various professionals. And we've also developed over the last few years a flagging system that we can actually have more than one address for that patient. So we can have, the neuromuscular centre where a lot of them go for their physio as one of the centres, that if the ambulance service gets a call from there, they know that this patient is on the alert. But it's taken years to evolve, and it's still evolving. We'll probably still keep changing it.
Yeah, that's another point that, in fact, Derek made, that you learn on the job. Of course, you're not just supposed to learn on the job, but you are certainly supposed to learn on the job to get the fine-tuning that you need for your patients. The other thing that Tracy... I
guess if for me to put through, because that sounds very much Duchenne emergency care plans. So because I'm aware that for a lot of people, motor neuron disease is something that's an evolving thing within Europe. So adult conditions where actually you're diagnosed and you know that things are going to deteriorate very quickly. We're trying to normalize the conversation about what your requirements are, what your preferences are in the future. So it stops becoming this huge conversation that's always clinically initiated, but it's something that patients are pushing for. And as we all know, if you have a patient knocking on the door who's saying, I want this, it tends to happen more. So we know from research that patients are waiting for us to initiate the conversation because they already know the prognosis of some of the stuff they're getting. If you diagnose someone with motor neuron disease, you are not telling them that that's bad news and they don't know that already. So we're trying to normalize the conversation and saying to patients, you need to tell your doctors, your healthcare professionals to make sure that the conversations are happening. Don't wait for them if they're not having it. The other thing is to do advanced care planning in stages. There's the do not resuscitate order, which is part of it. There's what do I not want and what do I do want. We brought in advanced care plans first by doing the DNA CPR bit, because that felt the easiest to win within healthcare, to go, look, there's this whole bunch of people who, when they die, we're not going to be able to resuscitate them. So why aren't we doing this better? Why haven't we got better documentation? Then as soon as we got that in, healthcare professionals go, well, this is useless because we can't put the advanced care plan on. Can you write us an advanced care plan? So getting people to change behavior in little bits, I think, is the way with this, rather than presenting people with a 20-page document that they're all going to go, I haven't got time to fill that in. Does that mean? I'm really sorry, I gabble and get really excited and talk quickly. So English people have difficulty understanding me, never mind other people. So please tell me if I'm talking too quickly.
You're talking loud and clear. A last point I would like to discuss with you is something that Tracy said about expectations, what the patients expect, what their parents expect, and with pediatric patients, there is not infrequently a mismatch. And besides the mismatch between patient and parents, we have also sometimes parents with misconceptions that basically are hurting the patient's care. So what is your experience with that, and how do you do it besides talking with people, of course?
I'm deferring to you again.
Yes, I think it is difficult managing expectations, and certainly I suppose we're thinking more about our sort of adult population and, you know, sort of those that have transitioned. And as part of that transition, we try to do some of our clinic with the patient alone or with their PA or carer rather than the parent. We're quite fortunate we have a psychologist in our team that can sort of support very often the families and the parents with this, because I think it is a big thing for them to let go, but also it's a big thing to have that discussion about palliative care and choices and wishes around, you know, sort of death. Certainly I had a young lad who did have some learning difficulties, but actually had capacity and had a very severe cardiomyopathy as part of his Duchenne. And we thought he was going to die when he was about 10, but actually didn't die till he was 19. But in the last sort of 3 years or so, he was very active in renewing his care plan and what his wishes were. And this was quite distressing for his mum in particular, because she did not want him to sort of not have everything, whereas he was drawing the line at certain aspects. And in the end, we had to have an independent arbitrator that came in to support him with this. And it was all very amicable, but mum just was so caught up with it emotionally that she couldn't handle it. But in fact, he had the death that he wanted. He did end up being ambulanced to the acute hospital, but the acute hospital did take his wishes into consideration, and that he would need invasive ventilation at that point. And that was one thing he did not want. And so actually they made him comfortable and transferred him to the local hospice, which was what his wish was. And in fact, the ambulance men managed to record his last words, which he said in the ambulance as they were taking him to the hospice, that he loved his mum more than chocolate, which was, you know, fantastic for him, because that was, you know, sort of his love. And they were able to give that tape to mum. And he spent 2 days at the hospice in and out of, you know, sort of consciousness, but had his mum and his dad next to him. And that's what he wanted. But it is very difficult. And yes, we had to have somebody independent that helped us to be able to do that and honour his wishes.
Okay.
I guess where my experience is different is that I don't do under 18-year-olds at all. So I haven't built up a relationship with the parents of me being the one that breaks news to the parents, and then the kid isn't involved in it. So there's a change in the relationship of the clinicians. I'm an entirely new clinician who's coming in to speak to an adult, and the parents just happen to be there. So sometimes that means I haven't got that history that makes it easier to kind of establish, well, and what we're doing is that we've got someone who has got autonomy, who can tell me what they want. You're not completely out, but actually the focus is now on there. And I think making that break with a different clinician often helps. But then I would argue that us trying to manage expectations and be honest in how we talk is just part of being a good doctor and a good healthcare professional, isn't it? That's what we do. And this is just part of it.
But it's very difficult. Okay, thank you.
No one said it was easy, but you know.
Okay. Thank you very much. Excellent talk. And thank you very much for this. And I hope to meet you soon, very soon, to talk about something else within your round. Okay.
Happy New Year to everybody. And for those who celebrate it, happy Christmas.